Okay, so tonight we have Dr. Basem Azab joining us from New York. He will be giving us talk about ERAS protocol and Whipple patients. Thank you for joining us, and the floor is yours.
Thank you. So I'm gonna try to take these like aside. Okay, I see all the faces that I love to see. I see Dr. Medhat Khafagi in the background. Uh, it's always like a pleasure to meet, and I wait for this invitation, and I really enjoy every time I spend with you. Like this is again, it's very dear to me. The place I stayed, and I lived for 3 years, trained by really giants and heroes, and gained my first steps to learn surgical oncology. We are talking today about our ERAS protocol and Whipple surgery. I was searching the history of Dr. Alan Whipple, and it seems like he's one of my great grandfathers because he trained someone, trained me. He was born in Iran to a missionary family, 1881. I was so impressed that he did not start working on pancreas resection until he became almost 50 years old. And his first Whipple to be in one stage, because he used to do the Whipple in two stages at least, resection and then stop, come another time to do the reconstruction. But he did the first Whipple as we know by 1940, almost 60 years old when he did that. Dr. Whipple, he did it only 37 Whipple surgeries in his lifetime. So it is amazing what we enjoy now. Like many of us, I'm sure, passed this number. Today, we're talking about ERAS, or enhanced recovery after surgery. It is started by cardiac surgeons, then moved to colorectal surgeons. They called it fast track, and then they harvested more and more until we have that term ERAS. As we all know, before I leave Egypt, it was like the National Cancer Institute was like covering over 20 millions, Cairo, Giza, and the suburb. I'm sure the numbers getting way higher than this 20 millions. And in addition, the hospital infrastructure in Egypt and everywhere, we have the same problem that we have a growing population with more elderly, more complicated surgery, and more potential to help people, but we have limited health system resources and hospital beds. We all, as doctors, like focus more on individual relationship and self-centered, and focus more about our success and each surgery we consider it as like a piece of an art that we admire, rather than look global and how much we can help the entire community, the entire population that we serve, to make sure that most of the patients receive their treatment, none left behind. With that, there was a huge need for enhanced recovery after surgery. So you empty the bed and you're ready for the next patient. It's important in many aspects. Pay for performance also rising. Anything that you cannot improve, you cannot measure, you cannot improve, it will crash eventually. I remember I heard that from Dr. Khafagi long time ago, that, and back then I did not understand that he was saying that the only solution is privatization, like to make everything that really costing certain amount, someone has to pay for that. In United States, they were talking about like make the college for free, like what we enjoy in Egypt. But many times we say someone has to pay. If you make the college tuition for free for everyone, who's paying? Someone has to pay. So pay for performance means every patient going inside a hospital, someone paying that. And you could say the government, social medicine in Europe and Canada, we pay for that, all of us. But it gonna come at the end from each one of us, and if we abuse it, we destroying our economy and our system. Specifics for NCI in Egypt, I remember, I think as someone trained in Egypt NCI before come here to the United States, there was a need for turnover. And I do remember admitting mastectomy patient before their surgery, which completely is gone away now. We don't admit breast cancer patients. We don't admit many of the patients that need like diagnostic laparoscopy, Mediport, all these ambulatory procedure has nothing to do to stay in hospital. Improving the training, improve the the efficiency and saving the hospital beds, which are so precious if you think about it. So there is something now called ERAS Society. I'm sure most of you know it. It started by two colleagues, but I think Dr. Henrik Kjeld, who's Danish, and you could say that most of that work coming from Europe as a social medicine, they're so careful about using the resources. They started this about 24 years ago, 2001. They started creating a society, and they make the meetings and start to shaping more and more ERAS protocol for each organ, for each system, and that what we have now. Okay. This is the 2012, the countries that were integrated in that ERAS society. You could see like most of Europe, Canada, and when you go further, start to expand. I was searching, is Egypt included in the ERAS society? Do we have any affiliation? Did Egypt one of the country that share? I cannot say for sure. I will like if one of you give me any input for that, but we certainly from Egypt publishing papers on ERAS protocols. So we are already started, and I think most of the work coming from trauma surgery. I will touch on a few points. As we all know, Whipple is a demanding procedure. Preparation is really vital. The technical part, we could talk about it in a separate session, and I enjoyed listening to many of the sessions. Dr. Hisham is trying to put like really wonderful group of presentations, and I really admire the work to have it on YouTube and can share it with others and keep that treasure. Talking about today is just preparing the patient before surgery, what you're doing inside the OR, and what you do after surgery to make the patient move faster and more efficient back home, eating and drinking. We are not talking about technical aspects inside like the OR for that type of surgery. So preoperative anemia, we all faced it. I remember as like a very junior resident, you're talking about like maybe 26 or 27 years ago. The focus was if someone anemic, you give him blood transfusion to improve his anemia and correct it and take him to surgery. Is not anymore. I could shock you if I tell you I did Whipple surgery for a patient a year and a half ago. While he's on the table, he was so pale. He had radiation, duodenitis, bleeding, and I will be shocking you if I tell you I did start my surgery with a hemoglobin of 4. I sent like a CBC when I felt like after anesthesia, he's like really pale. I did not believe the blood work that was done a couple of weeks before the procedure. And here it was, hemoglobin of 4. He did well. He didn't require any aborting the procedure or like doing anything. We continued the surgery, and we not anymore into like rushing for blood transfusion. The medical management of any anemia, most of the time, if you want to treat the etiology of that anemia, B12 deficiency, folic, iron, find exactly what the real cause of anemia, it will take 3 to 4 weeks, which is most of the time could be done, but not feasible in many cancer patients. Transfusion will correct the anemia rapidly, but will add to the mortality and morbidity. And I would really advise, as much as you can, avoid that route if you can. I think you could go down even to 9 or 8, or if you're careful, by hemoglobin of 7, you could get away with that type of surgery if you're moving. And many times, I remember Dr. Sami Ramz was saying, you give blood transfusion. I was sharing with him and others from the institution that I don't book blood transfusion, and we don't book blood units when we take a patient for Whipple. We used to book like 1 or 2 units, but not anymore. Just do type and screen. So transfusion, as we all know, affecting the immunity. I remember Dr. Kapagi was used to do auto transfusion, take blood from the patient, keep it so he can use it during surgery. We are not doing that. I'm not sure he's still advocating for that, or he changed his practice. But definitely, as much as we can, we corrected the anemia if something medical, but we are not really obligated or compulsory to hold ourselves from doing surgery for anemia. We have no evidence that normalization of hemoglobin before surgery is beneficial until now. We don't have a level 1 evidence for that. So what do you do before surgery? Before coming to the hospital, the patient doesn't get admitted to the hospital, by the way. If I have a patient who's doing Whipple, usually come from home, that usually alleviates the risk. Most of the time, we do only 1 Whipple a day. I don't remember I have seen a surgeon doing 2 Whipple a day, although it could be. Most of the time, we just have 1 Whipple a day for each surgeon. We give the patient clear liquid diet the day before, clear liquid diet until midnight. They don't stop like eating until midnight, and after that he still can have some clear even 2 hours before surgery. So my patients surgery at 7:30, I tell them at 5 a.m. you could drink apple juice or something called Ensure Clear, which is a protein supplement, but without fiber, without any dairy products. They could have it 2 hours before surgery. Stimulate the emptying of the stomach, sugar load, attenuate a little bit the sympathetic overtone. And we give the patient in the preoperative suite, while they're waiting for the surgery, we give them Neurontin 300 milligram and 1,000 milligram of Tylenol, and we give him also sometimes Siloxib or not, scopolamine patch, and we heparin 5,000 subcutaneous. All that we give to the patient just before roll them to the OR. And we apply to the patient a bear hugger and give them warm environment around their body so they don't get exposed to hypothermia. And I do believe hypothermia is a big impact to affect the immunity, wound healing, high chance for pneumonia. I think any one of us have a bad cold the night, he won't be good the next day or even 2. Then inside the surgery, the anesthesia is really getting on board for that. All the anesthesiologists are so familiar with the ERAS protocol. I think we have a wonderful presentation by our team, and Dr. Hisham, you could direct us to that lecture that was given before by our National Cancer Institute anesthesiologist. I forgot her name, was my professor. And it was a wonderful lecture. I learned a lot from her. Extreme of fluid balance should be avoided. By this, I mean, sometimes we go to each side in either far left or far right rather than be moderate. So giving too much fluid, like kind of like we all know, give 1 liter of fluid every hour you spend in the OR. I don't think this is the right way. And definitely 1 liter every hour, if you stay in the OR 6-7 hours, you're talking about 6-7 liter because of evaporation of the fluid. I don't think this is right at all. And every time we did that, we were penalized. We have arterial line measuring the like the cardiac output, going more toward the dry side, but not too much dry, because if you decrease the perfusion, you will affect the oxygenation of the tissue. If you also make the blood really diluted and you flood the patient with fluid, you will cause tissue edema and will also affect the oxygenation. So moderation is important here. Balance toward the zero. We have to have the multimodal analgesia, avoid opioid as much as we can during the anesthesia and after anesthesia. As we said, we give the patient gabapentin, Tylenol before taking him to the OR. And we don't use epidural. I used 4 years ago, we used to have every patient I did like has epidural. I moved now to bilateral tab block. I'm not sure what is the practice in Egypt NCI, but I found the bilateral tab block transversus abdominis block by liposomal bupivacaine is actually the best if you have that option. It is a fat emulsion of bupivacaine, and it covers about 5 days. And usually, if you give it in the right plane, where the nerves run between the transversus abdominis and internal oblique, I have many patients. I didn't need to give them except Tylenol when they get out of the hospital after 5-6 days. When they do well, they have some pain and I was shocked when I talked to the patient. Yes, I have pain. Where is your pain? Oh, pain from the tube, like in my throat, or pain in my shoulder from having the arm stretched out, but nothing in the belly. It does work. Preoperatively, also, we optimize all the medical disease treatment. Stop smoking, alcohol also are important. You try to prevent the nausea and vomiting from a start by many modalities: before surgery, after surgery, during surgery. Reverse all the neuromuscular blockers well, because it does affect the recovery. This is coming from University of Washington, but I will show you in each slide what you do in day 0, day 1, and what we do in our system here, which a little bit different, but I think both are acceptable and you could adopt them. So I might try to point to not to read everything, but try to point a few things. Daily weight, this is go without saying. Incentive spirometry, it's something cheap and simple, and we always teach the patient how to use it right. The urine output and vital signs every 2 hours, it's crucial. And if they are collected right, I could look at the numbers without seeing the patient. I know if he's doing right or wrong. We have to be familiar with when I'm talking now, I'm talking to the junior level residents and others. They have to be familiar. What is really tachycardia mean? 100, pulse of 100 is not normal. To see a patient all the time 100. What is the normal blood pressure for that specific patient? A patient who's taking 4 medication for blood pressure and now has blood pressure of 110/50 without any of his hypertensive medication is not doing well. Probably his blood pressure should be higher, and we have to be keen about how you treat that blood pressure, and it's an art. Medication that we use, beta blocker. I don't think we use any more beta blocker routine, but if someone has beta blocker before, it is a must. We have to continue. Or someone has arrhythmia, then we address it with beta blocker. But we don't use beta blocker as a prophylactic. The pantoprazole or esomeprazole, one of the proton pump inhibitor, it's always routine. You give Zofran for antiemetic. I don't use insulin drip protocol, and I don't think you need it, but that's from University of Washington. Pain-wise, I used Tylenol. I use here, you could give IV if you have it. 1 gram is a great option. You could use the syrup through the angiotube, and gabapentin, there's also syrup of that. The writing here, IV PCA, patient-controlled analgesia. It's a good option, but I usually try to avoid that by the tab block. And we could talk about it in the question, because I do believe any opioid really delay everything. The fluid balance, like target urine output more than 25 ml per hour. I usually don't go panic the first day, and I care more about the creatinine level rather than urine output, because we all know that there is a fluid retention in the first 24 hours. So I don't go like too much into like flooding the patient with IV fluid the first day. I accept like low urine output as long the vital signs are good and the patient looks good. I'm not worried about bleeding. I'm not worried about catastrophe or patient is not cardiac, just waiting for any hypotension to clog his either cerebrovascular system or coronary system. Otherwise, I go slow with like not really chasing the urine, but I chase the creatinine. The D5LR is a good option. Chewing gum, modified clear liquid diet. Here, I don't start the first day. I think you should start maybe next day, but you could give the patient always ice chips, sips of water. Like if the patient making up a couple hundred saliva and couple hundred of gastric juice, there's no point to hold the patient from having 100 of cc of ice chips or sips of water. It doesn't make sense to hold that. I just care about if the patient is with it, like awake, and he's not gonna aspirate. If he's like awake and full awake, I give him ice chips and sips of water, even after like couple hours from surgery when they are awake. I check something called water swallow test sometimes to make sure that they are not coughing or any risk of aspiration, but they can handle sips of water and ice chips. In the day one, we start heparin sub-Q. By the way, we started before surgery. We continue. I actually like to give heparin sub-Q, and in the OR, if we continue, then we plan for Lovenox 45 milligram every 24 hours. That make you clear your mind that you didn't miss any dose of DVT prophylaxis. Again, the pain management and the same thing, like nothing dramatic. But we send drain amylase post-operative day one. It depends. Most of the time, I put 2 unless I feel like very good about the anastomosis. I could skip the drain. I have worked with surgeons that you don't put drain at all, no drain, no angiotube, and patient did well. And sometimes I feel like, why am I doing that? Like the drain didn't put anything, and it put like maybe even 100 or a couple hundred, and patient didn't need it. But most of the time, I would say 99%. My patient will have drain, and I do drain amylase with a serum amylase post-operative day 1 and 3. What is the practice that we do here at Northwell? We do D5LR, we do PCA or epidural. I use tab block. We do pantoprazole, DVT prophylaxis, labs as routine. I'm sure you all do that. And the nasogastric tube, we leave it for low continuous suction. Many times I say, oh, it's not continuous suction. I know that you need it intermittent. No, the Salem Sump tube that has a blue port that's venting and getting the air out, you don't need to do it intermittent suction. I would do just low continuous wall suction and flush it with a clear liquid to the clear port and with air to the blue port, and I keep the Foley first day, the post-operative day 0. That we keep the patient in the PACU. We don't send the patient to ICU unless we're really running out of beds in the PACU, but patient could stay like after surgery in the holding area, and next morning you go to the regular floor. Post-operative day 1, patient move either from the PACU or from the ICU to the floor.
What is PACU?
I'm sorry, PACU is okay. PACU is post-operative care unit. Post-operative admission care unit, like what you call it, when the patient finished the surgery, where you take him? Dr. Sham?
Yes, so intermediate care.
You call it intermediate care? Right after anesthesia, you keep them where?
In the recovery.
Yes, the recovery. That's what I meant. PACU is the recovery. Okay. So post-operative day 1, we send them to a floor, regular floor. We remove the nasogastric tube if the tube is not putting more than 500 cc. Sometimes I use this trick that I give the patient contrast through the tube and get a picture bedside. And if I see the contrast traveling all the way down, give me another layer of confirmation, but you don't have to do that. You just make sure that the tube is not clogged and you in a good position by just regular X-ray. You already felt it during surgery. You don't even need an X-ray. And if it's less than 500, you could take it out. And clear liquid diet, just like a small volume, 30 cc an hour should be fine and should be handled well. Then you drop a little bit the fluid to D5LR, 84 if you were giving 100. Continue non-steroidal anti-inflammatory drugs, maximum for 3 days as needed for pain, not like standing order. Give him Tylenol or heart Tylenol, gabapentin, again, syrup, and the tab block should help you with that. You remove the Foley post-operative day 1 and make the patient go around the floor, labs for 3 times, and check again the drain amylase from both drains. In University of Washington and other places in post-operative day 2, they changed the heparin to Lovenox. I don't think you need to go crazy about it. Heparin's fine. Lovenox is fine. Lovenox would just make it once a day for the patient. So it's easy for patient and nurse, maybe more expensive, and also alleviate the chance for mistaken to miss a dose or give like duplicate dose. And the pain management, as we agreed, multimodality as much as you can, avoid opioid by all means. And the rest is, I think we could skip it. Post-operative day 2, we continuous clear liquid diet. We're dropping more and more the IV fluid. I learn many times I see the patient and say, oh, he gonna get dehydrated. 40 cc an hour is nothing. They actually handle it because in the OR, they give all the time fluids, and the body in the fluid retention status is still holding that, and it starts to release it by post-operative day 2 and 3. That's when you start to have this like syndrome of tachycardia, hypertension, deoxygenation, hypoxia, tachypneic, and restless, and putting a lot of urine. And I always teach my residents, give me any scenario giving you these 4 things: tachycardia, hypertension, tachycardia, hypertension, hyperapnea, and polyuria, and hypoxia. It has to be fluid overload. Now is the time the fluid going back. And it's actually a good sign that you don't have a leak or you don't have a bleeding. So now the fluid that you give during the OR anesthesia time, now the fluid getting back from the interstitial fluid, from the extravascular compartment back to the intravascular, it is a good sign when I see the patient tachycardic, hypertensive, deoxygenated, putting a lot of urine. Wonderful. When I see a lot of urine, tachycardia, hypertension, Many junior resident, the first thing reflects, oh, he's putting a lot of urine and tachycardic. What's the answer? Give fluids. And you shouldn't give fluids. You cannot race with the kidney. The kidney way smarter than us. It's a design way better than our mind. So most of the time when you have that scenario, tachycardia, hypertension, polyuria, deoxygenation, the patient breathing fast, it is not a septic shock, it is not pulmonary embolism, it is not anything except fluid overload. There is no other explanation. We could share it in the questions, in the comments at the end. So drop the fluids, walk the patient. You see the Foley already. Post-operative day 3. Let me see, how am I doing with the time? Post-operative day 3, clear liquid diet still. Dropping the fluid, as we said. We give the patient Senecot to stimulate the colon to move. But I give the patient suppository, bisacodyl, dulcolax, stimulate the colon to work. Sometimes I even Reglan. I try to stimulate the stomach and the colon to work and get back and function. And I remove the drain if the amylase value less than 5,000, which to me was like, when I did that first, was like so hesitant. The patient did well. And if the patient had a drain that putting clear pancreatic juice or bile, I'm not going to remove it. If I have a patient also, I know they're going to leak. It's like a very soft gland, very notorious small pancreatic duct. Maybe I'll be hesitant to remove it. But if I feel good about the anastomosis and the drain color is just serous sanguinous and it's just a 5,000 or less, I would take it out. We could go to my protocol. Post-operative day 4, we advance to full liquid diet. Now they can do some stooling, and we already give them Dulcolax suppository. We give them Senecot, and we stimulated their gut even with sometimes with Reglan. Again, minimize opioid as much as you can. If they can tolerate half liter of full liquid diet, we could switch everything to oral medication like Protonics. We should have switched it, and the rest, and avoid again and again. I avoid opioid. Here it says like give oxycodone, but wait for the tramadol to work. Give 1 hour to work. I really barely use these oxycodone and tramadol and dilaudid. And I think we are successful about 80% of the time not to give these patients opioid. And when I tell the patient there is a price you pay if you take opioid, they always cooperative with me. And okay, I could use the Tylenol. Nobody told me that. All right, and I used the doctor. It did work. So it's good to communicate with your patient and tell them if they are in pain, encourage them to use Tylenol or ibuprofen rather than ask right away for big guns. Post-operative day 5, now we are moving to remove the second drain if the amylase is still low and discharge the patient on soft diet, low residue diet. And I tell my patient, you take for your pleasure like a scrambled eggs or mashed potato or a piece of chicken or salmon or like broth or a piece of meat or even a piece of sandwich, but depend more and more on liquid diet until like the gut work. So I don't rush them as like you have to finish the entire or 50% of your tray so I feel good about you. No, I accept that they still need time to recover, and I give them the majority of their nutrition based on full liquid diet, but they get some solid food. We go now when the guidelines for ERAS for the Whipple was solidified, I think in the last decade early was published, and you could retrieve that from World Journal of Surgery in 2012. But look at what happened about the publication from ERAS. In 2013, we have less than 100. In 2019, almost 500. We keep hearing more and more people actually accepting. I could tell you that I am a converter. I was like so hesitant, and I feel like this is just for economic reason. This is political view. This is just from hospital system pushing us to discharge the patient to get another patient. It's very skeptical how I'm sure it's gonna work with an old guy who has chemotherapy, or like, oh, this is not for this patient. It has to have like the 40 years old male athletic marathon runner. No, it actually work with all the patients, and if they fail, they fail. Like, but it does work, and I did practice that, and it does decrease the length of stay and decrease the anxiety. So if there is improvement of gastric emptying by the ERAS, actually yes, there's papers supporting that. This is a randomized controlled trial, 50 patients from 2005 2009 compared to 75 patients who used the ERAS and were significantly reduced in the fast track, and that confirmed by multivariate analysis. What are the factors that make someone fail? Like, you put someone in enhanced recovery, you did all what I said, but you come back to me, it's like, it didn't work. Like, I tried it with one patient, it didn't work. I tried it with 4 or 5, one of them didn't work. So they did a study, they found some patient, yes, it doesn't work. And this one over 176 patient, if you can read that line, what are the failure considered? A prolonged hospital stay, readmission, reoperation, they consider that as failure. So what the people failed was 59 patients. 33 of them had prolonged length of stay. 18 were readmitted. 8 went for reoperation. What are the criteria that really led to that? Elderly population, for sure, above 70. Malnutrition, low albumin level. I think albumin is more than just a nutrition marker. It's inflammatory and nutrition marker. And I did about like 4 studies, I published it. I think there is a relationship between the albumin and cancer. And like when I see someone with an albumin of 4.5, I feel they can resist any cancer. The Anesthesia Society score for comorbidity, ASA more than 3, I think also predict. So someone comorbid, someone old, someone malnourished, usually they're gonna fail the ERAS trial. I mean, ERAS protocol. What we should do then, you just put them and just wait. If they fail, they fail. You cannot anticipate that. Delayed gastric emptying, I think, is one of the common complication that all of us, we did the Whipple surgery, we just waiting until the patient eat and drink. That's usually very gratifying. And when it happens, very annoying. What is a definition? There are grades according to the International Study Group of Pancreatic Surgeries, and it says like grade A, B, C. I think most of us familiar with it, 4 to 7 days. You need to put the nasogastric tube back. It's considered like delayed gastric emptying. And so B, 8 to 14 days, and not tolerating solid for 14 days. Vomiting, and you still need prokinetic agents to make the stomach work, and so on, like more than 14 days and 21 days not tolerating solid food. It is a grade C. So you could appreciate these are the definition, and some of us might agree, some of us might disagree. There's multiple definitions. I think that's what most of us will use. And that group, international study group, think they have for the fistula, and they have also for the delayed gastric emptying. So there is a randomized controlled trial for routine use or post-operative nasogastric tube decompression after Whipple surgery. And I was amazed to see that there is a trial. So they randomize a patient after Whipple to remove the tube or keep the tube. So orogastric tube, by the way, OGT, orogastric tube. In the surgery, we put orogastric tube and remove it right away. 57 patients. And the rest, 63 patients, group 2, they had what we all do, nasogastric tube. Just put a tube from the nose to the stomach to decompress the stomach, make sure the bile is like flowing, the biliary limb is not distended, not putting back pressure on your anastomosis between the bile duct and the jejunum, the classic. They found no significant difference. This is an abstract. It's not published. And I'm surprised 2018 is still not published. And that put me like kind of skeptical about it. Why not published? But they found no difference if you keep the tube or you remove the tube. I wouldn't advise any of you to like get the patient out of the OR without a tube. We don't do that. I keep the nasogastric tube. I take it next day. If I see the patient has less than 500 cc, we take it out. Otherwise, we keep it. But they found no difference if you take it out or you leave it or leave it after surgery. Right away after surgery, they found no difference in reinsertion of angiotube or like a delayed gastric emptying or an ileus or any length of stay. Nothing changed. There is also association between the patient characteristics and Whipple procedure outcome before and after implementation of an enhanced recovery after surgery protocol. Not all the papers are encouraging. There are some papers are bringing some negativity about ERAS protocol. So, for example, that paper, you might say, oh, it did not significantly change length of stay or readmission or mortality. But you know what? If it didn't change, at least you didn't go panic with nasogastric tube forever, leave the drain forever. So even a negative trial or negative study with the ERAS is considered positive. Positive to remove the tube faster, positive to get the drain faster, positive to give the patient feeding faster. So it's not bad if it doesn't improve anything. There is also studies about early or late drain removal, and this is like I've been on each side. I've been like very advocating leave the drain forever. I never had any problem, and I did have a problem leaving the drain. Sometimes I have patients suffer from leaving the drain, but like sometimes you feel like it's a judgment call. It's an art. I cannot force you. But there are paper about early or late drain removal after pancreas surgery. And you could appreciate from that the pancreatic fistula, and by the way, this is a randomized trial, almost 50 patients each arm. The pancreatic fistula was more in the patient, you kept the drain more. And I tell you, it makes sense. Maybe you're sucking more, like you're trying to open something, it could be sealed if you take it out. Many parameter reoperation, but is not significant. But you could appreciate the length of stay was more with late removal. The hospital readmission was more. The pancreatic fistula was more. I cannot deny that. Of course, as this table, I think we all agree on it, that patient with soft pancreas, a small pancreatic duct, they have a higher chance to leak. So I think that table is like just a reminder that we have to consider what is the material that we work on in the surgery. So after surgery, it is an art, and there is no way I can tell you exactly what you have to do for every patient, because the surgeon in the ward knows who's gonna do better than the others. Early drain removal after Whipple, again, it's another trial, was published in Journal of Pancreatology 4 years ago now. And they found, again, it is safe to remove the drain, even if it's up to 5,000. So you don't have to go panic when the drain amylase is high. But again, the clinical features are not there. Like patient doesn't have a biliary output, patient doesn't have a pancreatic juice, doesn't look like bleeding. You could take it out. And postoperative day 3 for the last one. what take-home message I would say? Remember, give the patient clear liquid diet. Even 2 hours before surgery, they can drink, and you have to be cooperative with your anesthesia. Anesthesia team has to be familiar with that ERAS protocol. When I say clear liquid diet, don't give them milk before surgery. Don't give them regular Ensure protein drink that has fiber. Clear mean clear, like apple juice, Ensure Clear, or water. Sugar before surgery is good. Decrease the sympathetic tone. Give the patient some calories. Avoid hypothermia. And again, it's a very important factor in recovery. Minimize opioid and use multimodality analgesia. You could remove the NG tube first day after surgery if it's less than 500 cc output. You could remove the drain post-operative day 3 if it's amylase less than 5,000 with no risk clinical features. Give the patient clear liquid next day of surgery after remove the NG tube, and give soft low residue diet by post-operative day 4 or 5 and get the patient out. I hope I did good with the timing, and I'm sure we could discuss more if you have questions or comments.
Okay, thank you for the talk. If anyone has a question, please raise your hand. You didn't mention sandostatin. Do you use sandostatin?
I use it, but it's not an ERAS protocol. I use it only when I have a very high risk patient with high volume. It decreases the volume. It doesn't change too much the outcome, but I consider it for a patient who has a soft gland. The anastomosis, I know it's not like I wasn't comfortable, very small, tiny duct, and the patient is very vulnerable and putting a lot of fluids. I use it.
Do you use it when you have a leak?
Yeah, I use it when I feel like the volume is high and there is a significant pancreatic juice in the drain. My Liz is high. I know the anastomosis was not the best I could do. Soft gland, small duct. Then I use it, and I could tell you I'm not sure. I use it to feel comfortable, or does it change? There are many papers that suggesting, and I did not suffer any complication from that, and I don't think it's expensive. I think it's reasonable if you use the sandostatin. I'm not talking about long acting. Long acting is really expensive, but the short acting should be reasonable.
اوكي دكتور مدحت كفاجة.
اهلا، ازيك يا باسم؟
اهلا.
هو بالنسبه لسؤالك، هل انا لسه بعمل الاوتولوجاس بلاد دونيشن؟ طبعا يعني بحيث اصل واخد بالك، انا ممكن اعمل عمليات لانيميك بيشنت وما افقدش دم، لكن الدكاتره التخدير في مصر نرفس اما يسمعوا بنكرياتيك نكستوم ولا حاجه، ولا حتى كولون ريسكشن ومفيش دم بيحصل لهم هلع يعني. فما بيلتقوا الاوتولوجاس بلاد دونيشن دي بيحطوا لسانهم جوه بقهم يعني. انت واخد بالك؟
The problem with that, Dr. Medhat, the autologous blood transfusion itself, when you take it out, it creates pyrogen. You could be contaminated. It in a certain way, it burdened the system. Was like I feel like it could burden their system. Yes, their own blood, but you never know what can change.
Well,
in the
what
protein.
about the homologous blood transfusion? It passes through the same process.
Yes, but that's why I don't like even homologous.
It's not my idea.
Yeah, I know it's not your idea. No, it's published before.
Patrick Walsh في Johns Hopkins 1983.
Yes. No, it is. There are many professors advocated for it. It just very rare to see it practiced.
Well, in Memorial they don't practice, I know.
Yes.
Memorial is not good. But if you see them, they don't lose any blood during operation at all. So
no, we don't.
Dr. Jaitan Shah, who is the chief of head and neck, told me that he didn't use any blood for the last 15 years. which is
Yes, with the electro energy devices that we have now, the harmonic, the LigaSure,
yes, and
these
a type
devices
of
you want
dissection.
mostly bloodless.
Type of dissection. Also, you know that the homologous hemoglobin is very allergic.
Correct.
It causes fever, rigors, and everything.
Yeah.
And even you said that increase the morbidity and mortality. This
Yes.
is the homologous hemoglobin.
Yes.
We don't give, of course, plasma or something. It is packed cells only. And
Yes.
so the homologous hemoglobin is very allergic.
That's correct.
That's one thing. Well, I observed in your in one of your the studies you mentioned that 18 out of 50 something they were readmitted.
Yes.
Yeah, I think you have seen that.
No. 18 out of 50
Okay.
out of out of couple hundred.
No, it,
The 50 are the 50 are the
something.
old patient got complications. Some of them, the 18 got readmitted, 6 got reoperation.
Yes, 18 out of 50, 58 all the patients. Okay, that is too much. You know that
No,
most
it's
of
not.
the pancreatic cancer are over 70, right?
No, is not. Let me show you that again. That slide, because we
It's
this
here.
is the
59 patients.
yeah. Well,
You
because we
didn't
missing
say that
we're
they're
missing
above 70.
the top one.
Okay?
There's if
You
you can
didn't
read
say
the
above
first
60.
line, it's 176 patients.
176. Okay. You see, in Egypt, usually when the patient gets sick at home, they don't bring him early.
Yeah.
And they bring him dying, you see.
Yeah.
From complication. This is very, very common here. They accept any morbidity or mortality.
The
And
problem, Dr. Medhat, is you have to have a system. And instead of like living in a fear that, oh, my patient, when they go home, they're not going to come back to me, you have to have a system that,
I know. Also,
check the pulse and oxygen at home. It's $25. So I'm not sure how much like in Egyptian currency.
لا ما
But
هو
when we have
يعني
COVID,
انت واخد بالك يعني
Yeah.
مثلا انا بمر ويا الدكتور فؤاد عبد الشهيد ولا حاجه في الاسم بتاع GI سيرفيس الحقيقه I got sick in my stomach. ليه؟ كل اللي اتعلمته ما بتعملش. يعني مثلا ما بلتقاش حد محطوط الSCD مع ان انا في البرايفت اضطريت لان المستشفى مثلا ما رضاش اشتريت 2 عشان العيانين بتوعي
what is SDC?
اللي هو الكمبريشن ديفايس بتاع
Oh, yeah.
جندال. not a single patient حاطط الSCD.
No, that's a routine.
دي يعني انا فاكرك عارف الاسم.
Yeah. No, it's
جندال.
sequential. Yeah, that's a routine. We have it routine.
روتين ايوه. Yeah, I know it's a routine. And everybody with a moderate or big operation has to have this SCD. Also, they don't use the spirometer.
That's a routine also.
Though in my private practice, I insist he has to buy the spirometer and use it for 10 minutes every hour while awake. I don't see that all the prophylactic measure you said is routinely done in our institute, you know. What I have learned from abroad is not used. Maybe it was used while I was in charge, but now nothing done. They put this Scaltitas abdominal binder, which I tried to convince them it is wrong. Do you use still these abdominal binders?
No,
think
not
you don't
really.
use it.
And some patient, they just use it for their comfort. I don't think it does any work. And we actually moving now. I was talking to Dr. Hisham to do more minimal invasive Whipple. So, and it's very rewarding to finish like a surgery with no incisions. So in that case, of
No,
course, we don't use it.
yeah, that will decrease the morbidity, yes. Well, I think what you wrote in this postoperative orders, most of them are not followed in Egypt. Most of them.
It's
don't
here. It's
know why.
individual efforts. It depends on the surgeon. But generally not. But if the
Not
surgeon
okay.
insists,
But
yeah,
I
generally they
taught
don't have.
them while I was in charge. I taught them all these things, and they don't put. Most of the operations are open, you know that, and they don't put a separate set for closure of the abdominal wall. You know, they don't do that anymore. Although I insist on that while I was in service in the hospital, in charge. I do it, of course, in private. Well, most of the perfection of big operation in Egypt is, whether it is during operation, after operation, is very poor.
Yeah.
And that is illustrated. I receive phone calls from Aswan to Alexandria from surgeons who got into trouble because they don't do any prophylactic measures during operation or after operation to prevent complications. Okay, that's
Thank you, Doctor.
Great. Thank you.
Okay, any other questions? Last chance. If you have a question, raise your hand. Okay, so looks like that was it. Thank you, Dr. Basem. It was a
Thank you,
wonderful lecture.
My pleasure, always.
انت
Always a
باسم
pleasure to have
في
you
نيويورك
visit.
نفسها ولا فين في نيويورك؟
New York, yes. Staten Island.
منهاتن ولا برونكس ولا
New York City. Staten Island.
منهاتن؟
Yes.
Staten Island. Oh yeah, you were in Staten Island.
We have a question from Dr. Yasser.
Sure.
Good afternoon, good evening, Dr. Basem. I'm trying
أهلاً.
to unmute myself, but I can't because Hisham is controlling everything. Thank you for thank you for this
Kill him.
smart lecture. I have one question. I don't think removing the drains early or delayed could affect enhancing recovery after surgery. Even we can discharge the patients with their drains with adequate home support. We do that in Egypt. Another thing. We have ongoing trial regarding enhancing recovery after Whipple was discharging the patient with hospital staying less than 100 hours, and it is recorded on the clinicaltrials.gov. And in this protocol, we stress on just few things. No preoperative long fasting, strict fluid control, intraoperative, even with inotropes if we need, strict pain management, so the patient should feel pain-free, should be pain-free, strict mobilization immediately at the night, and we leave the drain as it is bringing something, even 200 cc per day or less or more. We start serum amylase on post-operative day 3 and compare it with drain amylase. And we start soft diet on post-operative day 2, and we think this will enhance his recovery. We strictly control his glucose level. We measure it every 4 hours, and we give him regular insulin, and on day 0 through the overnight ICU. They usually give him insulin drip. And we discharge him morning and post-operative day 4, provided adequate nursing, home support for him. And we found that this protocol is really amazing for this patient, and lowers a lot the hospital cost. Interoperative, one of the most important things we found that gentle and proper tissue handling greatly improves the patient recovery after this long and heavy procedure for him.
Do you do minimal invasive, Whipple? Yes.
No, just a right subcostal incision. We started outside our NCI the resection with laparoscopy, and still for myself, I still don't trust the multiple anastomosis laparoscopy for the patient's sake, not for my sake.
So there's no minimal invasive done yet in Egypt?
There is no total the
No, some
procedure
people
totally
do it, but it's not.
minimal invasive. The resection in early cases we did the resection just laparoscopically.
Yeah, the resection laparoscopic.
Yes,
is
and we
doable,
open
but I would advise like think about robotic, because I think the limitation, the laparoscopy is doable, but when I tried to do the laparoscopic reconstruction, is very demanding.
yes,
But the robot really made that reconstruction really doable, and many surgeons they may concur with that you need the robot to have the 100% minimal invasive weapon.
well, at the time we had a robot at our NCI, but the service completely stopped and outside the universities the cost is very high.
Yeah. Okay.
And even
Not
the
that-
laparoscopy
not
CME
that
available
high, yes.
outside. And even the laparoscopy outside NCI, the robot outside NCI is a CME and is not that like the Da Vinci system.
You mean SI?
CME.
Semi, I'm not familiar. I use
CME,
XI.
another brand. No,
SME.
CME is another brand.
Okay.
It's not a Da Vinci.
Da Vinci SI or XI, and it is not. It is not. Or no longer been in Egypt.
Okay. Thanks, Yasser, for this comment.
Okay.
Thank you.
Any other questions? We have one last question.
Okay. I'd like to ask about something maybe not related to the title of the lecture intimately, about the use of sandostatin routine post-operative and the use of substance like glue on the pancreatic jejunostomy to reduce the incidence of the leak. Your experience, please, sir.
Yes, I use something called VistaSeal. We used to use also other glue on all the anastomosis. In my opinion, it just pushing the declaration of any leak, and instead of happening the third day, will happen 7th, 8th day, will give more time to the tissue to stick together. Some may argue that, oh, if you wrap the omentum, will stick better. So if you have it, use it. If you have a glue, like apply it. But many times I felt like use it or don't use it. I don't see like a big difference. If you have a good anastomosis, it should work. You're asking about sandostatin. I just answered it earlier. I use it if the patient has high risk pancreatic leak, very small pancreatic duct, less than 3 millimeter, with a soft gland, and I feel like the anastomosis was not satisfactory, and the drainamylase high and the content clear pancreatic juice. I give the patient sandostatin, give them 100 microgram 4 times a day, and I continue that for a couple of weeks.
Does this answer your question? Yes. Okay. Okay. Do you have any other questions? Okay, that was it.
Thank you.
Thank you, Dr. Basem, and
Good night.
looking forward to the next time.
Thank you.
And looking forward to seeing you in Egypt soon. Are you coming anytime
Yes.
soon?
Oh, yes, yes. And hopefully this winter or fall.
Okay, so we'll see you soon.
Yes.
Thank you, everyone, and
Thank-
see you in 2 weeks.
Take care.
Good night. Bye-bye.